Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient comes to the emergency department after a sudden episode of right arm weakness and slurred speech. By the time you see them, the symptoms have completely resolved. The key question is this: was this a transient ischemic attack, a completed stroke, or a mimic such as migraine, seizure, hypoglycemia, or syncope? A transient ischemic attack, or TIA, means transient focal ischemia affecting the brain, spinal cord, or retina, causing neurological symptoms that resolve, classically within 24 hours and without established infarction. The important word here is ischemia. Ischemia means lack of oxygen supply. Infarction means tissue death due to lack of oxygen. So in a TIA, there is temporary oxygen deprivation causing neuronal dysfunction, but not permanent tissue death. MRCP trap: do not think of TIA as a benign event just because the symptoms have resolved. A TIA is a warning event. The risk of recurrent stroke is front-loaded, especially in the first 48 hours. That is why rapid assessment and treatment are so important. Now let us understand the mechanism. Think of TIA in one simple arrow. Embolus or in situ thrombosis leads to transient arterial occlusion, which leads to reduced regional cerebral perfusion, which leads to neuronal dysfunction without irreversible infarction, and that produces a focal neurological deficit. There are 4 common mechanisms to keep in mind. The first is large artery atheroembolism. For example, a carotid plaque can rupture, forming platelet-rich emboli that travel upwards into the cerebral or retinal circulation. This can give cortical symptoms such as aphasia or limb weakness, or retinal symptoms such as amaurosis fugax. The second is cardioembolism. Atrial fibrillation, left ventricular thrombus, or valvular disease can generate an embolus that travels to the brain. These events often produce abrupt territorial neurological deficits. The third mechanism is small vessel disease. Lipohyalinosis or microatheroma can affect small penetrating arteries and produce lacunar syndromes, such as pure motor weakness or pure sensory symptoms. The fourth mechanism is hypoperfusion. If a patient has severe arterial stenosis and then develops low blood pressure, the brain areas at the border zones between arterial territories may become underperfused, producing watershed symptoms. Now let us move to the clinical features. The symptoms of TIA should be sudden, focal, negative, and compatible with a vascular territory. Sudden means the symptoms come on abruptly, not gradually spreading over many minutes. Focal means they localize to one part of the nervous system. Negative symptoms mean loss of function, such as weakness, numbness, loss of speech, or loss of vision, rather than positive symptoms like flashing lights or tingling that marches across the body. In middle cerebral artery territory ischemia, the typical pattern is contralateral face and arm weakness or sensory loss. If the dominant hemisphere is involved, there may be aphasia. The key clue is that aphasia is a cortical sign, and it points towards involvement of the dominant cerebral hemisphere rather than a simple peripheral problem. In posterior circulation TIA, think about diplopia, dysarthria, ataxia, vertigo with focal neurological signs, or bilateral visual symptoms. MRCP trap: isolated dizziness or isolated vertigo is often not enough to diagnose posterior circulation TIA unless there are focal brainstem or cerebellar features. Retinal ischemia causes amaurosis fugax. An embolus enters the retinal circulation and produces transient monocular visual loss, often described as a curtain coming down over one eye. The key word is monocular. Monocular visual loss points towards the eye or optic nerve circulation, whereas homonymous visual field loss points towards the retrochiasmal visual pathway in the brain. Do not confuse TIA with its common mimics. Migraine aura often spreads gradually and may have positive visual or sensory phenomena. Focal seizure may cause positive motor or sensory symptoms, followed by Todd's paresis. Hypoglycemia can cause neurological symptoms and must be checked urgently. Syncope usually causes global loss of consciousness rather than a focal vascular territory deficit. Functional symptoms may not fit a clear vascular pattern. Diagnosis is primarily clinical. You need a precise onset time, duration, vascular territory, vascular risk factors, history of atrial fibrillation or anticoagulant use, presence of carotid bruit, and a careful neurological examination. Investigations are not just to prove that a TIA happened. Their main purpose is to identify the mechanism and prevent the next stroke. An ECG is used to look for atrial fibrillation or other cardiac causes, and prolonged rhythm monitoring may be needed if paroxysmal atrial fibrillation is suspected. Blood pressure should be measured because hypertension is a major modifiable stroke risk factor. Glucose must be checked because hypoglycemia is a dangerous and reversible mimic. Lipids help guide statin treatment. Full blood count, renal function, electrolytes, and coagulation tests help assess vascular risk, safety of treatment, and alternative causes. Carotid imaging is important when symptoms suggest anterior circulation involvement because significant symptomatic carotid stenosis may need urgent intervention. MRI with diffusion-weighted imaging can detect small infarcts and may reveal an alternative diagnosis. MRCP trap. Routine CT is not recommended for suspected resolved TIA unless an alternative diagnosis is suspected. If the symptoms have fully resolved and the story is classic for TIA, the immediate step is aspirin and urgent TIA clinic assessment. But if there is concern about bleeding, a mass lesion, or another mimic, then urgent CT or MRI is needed. Now let us move to treatment. If the neurological deficit is still ongoing, treat it as a stroke. That means emergency transfer, stroke pathway activation, and admission for urgent assessment. For suspected TIA with resolved symptoms, give aspirin 300 milligrams immediately unless contraindicated, and arrange specialist assessment within 24 hours. If the TIA has resolved and the patient is awaiting specialist review within 24 hours, aspirin is the immediate treatment. If the resolved TIA happened more than 7 days ago and the patient has still not been reviewed by a specialist, give aspirin and arrange specialist review within 7 days. After specialist review, high-risk patients may receive dual antiplatelet therapy with aspirin and clopidogrel for the first 21 days. After 21 days, long-term secondary prevention is usually with clopidogrel. Secondary prevention depends on the mechanism. For non-cardioembolic disease, antiplatelet therapy is used. For atrial fibrillation or another cardioembolic source, anticoagulation is needed once hemorrhage has been ruled out. A high-intensity statin reduces vascular risk. Blood pressure control, diabetes management, smoking cessation, and lifestyle modification are essential. If there is significant symptomatic carotid stenosis, carotid endarterectomy or stenting may be needed. If you remember one thing, remember this. TIA is not a diagnosis to reassure and discharge casually. It is a time-critical warning sign of possible early stroke, and the first 48 hours matter. Quick recall. A patient has sudden right arm weakness and expressive aphasia lasting 15 minutes, then complete recovery. CT is not routinely required because the symptoms have resolved and the story is classic for TIA. What should be done immediately while arranging urgent specialist assessment? The answer is aspirin 300 milligrams immediately, unless contraindicated, with specialist TIA assessment within 24 hours. A patient describes flashing zigzag lights spreading across the visual field over 20 minutes, followed by tingling that gradually moves from the hand to the face. Why is this less typical of TIA? The answer is that TIA usually causes sudden, focal, negative symptoms in a vascular territory, whereas spreading positive symptoms suggests migraine aura or seizure, rather than transient arterial occlusion. Do subscribe to the channel for further videos.